Just raise your hand. I'll be asking for yours. Just don't heckle. Yeah. Okay. Starting in three, two, one. Panel. I, as the Prime Minister here, is here to support the right to try. Why exactly? So, firstly, we need to understand what the current situation looks like for the patient. The patient is lying there, like they're just existing in this world. They've truly lost their hope. They have a disease. This disease does not have a proper conventional cure, and even if a conventional cure exists, it's not doing wonders. The they're they've lost all their hope, like majority of their hope of being cured again, and it's just looking in very bad for the patient and therefore for the families. Now, three reasons why the new experimental cure would be better than the conventional cure. Number one, the conventional cure already exists. If the conventional cure was doing good, then there wouldn't be a requirement of a new cure. So therefore, we need to understand that even though the conventional cure exists, it's not doing wonders, and people cannot have lot of hope when it comes to this conventional cure. Secondly, this conventional cure has already been tried out on multiple people multiple times, and the formula needs to be tweaked out, or the formula needs to be changed in order for the cure to work better. Thirdly, a lot of people fall into the trap of probability bias, and they automatically assume that there's a very high probability that this unconventional treatment is not gonna work, or it's just gonna harm people, and they automatically assume that there would be a lot of disadvantages related to that. But we need to understand that every day there are like multiple scientists, multiple students who go to the lab, who do research, who do experiments, and come out with different cures. But like less than 1% of these cures pass the clinical trials, and even lesser of them pass the first phase. Just because this particular cure has passed the first phase of trials, that there is a very high probability that it's going to pass the second and the third phase of trials, and therefore the cure will be successful. There's a very high probability, and I think the patient would want to risk whatever chances they have in order to take the cure. Now, why do I say that? I say that because once the patient takes the cure, there's not a slight probability, there's a very high probability of them getting better. This probability is extremely important. Okay, before I move forward, POI. Okay, seeing none, I'll continue. This this probability of them getting better is extremely important because number one, it gives them the autonomy, the autonomy to function. If I, let's say, I'm suffering from a disease like Alzheimer's or HPV or something of that sort, I keep forgetting things, I'm not able to work on my own. But like as soon as I take the cure, I don't it's not a miracle, obviously. I'm not able to, I'll not instantly get better, but I'll do get better. So as soon as I get better, I'll start able to contribute myself, like contribute to my family, contribute to myself. I'll regain the autonomy to function. I'll have the right to do what I want. I'll be able to back up my work. I'll be able to function properly. Secondly, because I'll be able to function properly, it would give me back my self-respect. I would not have to depend on people. I would not have to be fully like, yeah, I cannot do stuff on my own. Therefore, I need your help. So with the autonomy, I'd regain my self-respect. Thirdly, when I'm able to contribute, I have the chance of earning by myself. Therefore, I would be self-sufficient. I would have no stress of being like, oh, I cannot contribute. If I cannot contribute, or if I cannot do something, there's a slight probability that like my family will leave me or something. I'm a burden to my family and all that. So that is not going to happen, because like with the medication, I would kind of earn self-sufficiency, and that would be better because it would reduce the stress of me not being able to, like the stress of me fully being like able to depend on someone. Fourthly, it would also give me back my mental well-being if I'm able to fully earn for myself, fully support my family, I would mentally do better. And this mental well-being would therefore somehow have an effect in like making the treatment better. Yeah, go ahead. The
Why
POI.
do we have phase two and phase three trials at all if all drugs that pass phase one will end up being successful anyways?
I did not say that all of the drugs will end up being successful, but like if there are like hundreds of formulas, let's say if there are 100 formulas, only 10, 20 of them passed the first trial, and like only like let's say 10 of them or half of them passed the second and the third trial. But still, like there's like a 50-50% chance that the formula is going to survive the second and the third phase, and the person is willing to take the chances because like they already have limited time to live. The conventional treatment is not working at all, and like if we tell them that they're not allowed to use this experimental treatment, we are basically taking away like taking basically just delaying everything, and we can't afford delay because like delay equals death sentence. They don't have time to wait for phase 2 phase 3 trials. They don't have time to just like not take this trial because they don't know how longer they live. Besides that, at this point, they have like nothing to lose and everything to gain. They're already suffering. They're suffering terribly. Not only them, their families are suffering by just like denying them. We take away the hope and the psychological relief of them getting better. Once we allow them the access to these clinical trials, it reduces the regret in patients' families because like at least they tried, and at least they'll have something to gain. At least they'll have this feeling that they tried, they did their best in order to provide their family, in order to provide their family member with everything they could, and they did their best to make sure that they get cured of the disease. So, yeah, with that, DPM.
I thank the speaker for that fine speech. To begin the case for opposition, leader of opposition. Hear, hear.
Hello, panel. Hello, everyone. I'm Swetha. I'll be the leader of opposition for this speech. I'll be recording my speech. Yeah. Cool. So I'll start my speech in the reverse count. And yeah, for POIs, post the fifth minute. You may send a message in the text. So yes, I'll start my speech in the reverse count of 3, 2, 1. So, hello, panel. So, here's what the PM comes and paints to us. They live in a fallacy world where experimental treatments, the way it was put forward in the POI as well, phase one goes through, equivalent to being phase two and phase three. Its existence itself is being questioned in here, right? So, basically, it has been very clearly stated in the info slide that this is an experimental treatment, right? What does experimental basically mean? Let me put this forward. There is no full regulatory or clinical like there is just no full regulatory or clinical approval in the sense you just have a healthy dosage which has been confirmed. When we say healthy dosage, it is not lack of any further side effects. It is not lack of the stuffs which your conventional treatments are naturally not giving you. It is basically, it implies we don't die, we just survive. They have given us the fact that it has been up to a certain degree certified for you to be able to survive, to be able to sustain the pain, to be able to live your life. This is all that the healthy dose is confirming us. You're not going to die, right? So if we speak of effectiveness for the disease, or how is it basically better off in comparison to the conventional methods which are already present, which have been used for hundreds of years, and the research has advanced so much into this that we are seeing generic solutions coming out, right? We are seeing a massive segment of the population which has already, based on history, benefited from this. Now, when you're opting out of a conventional, obviously you can't try both together, right? So when you're opting into experimental treatments, it basically means you're opting out of conventional treatments. The way it was put forward, Alzheimer's. Come on, you said
POI.
Alzheimer's patient. After the fifth minute, Alzheimer's patient needs to be getting autonomy, right? Imagine them getting autonomy of making the choice. They don't even remember what they did a few hours back or few weeks back. When we have such vulnerable stakeholders present in the game, patients who have superficial knowledge or very little knowledge about the research, honestly, such people, they can be brainwashed into this and they can be made to believe, they can be influenced, let us say, by these major firms, these major organizations, medical research grounds. They can be easily getting free participants, right? They can be coerced by the doctors. So the likelihood of this being turned into a rat experiment, into an experiment where you need more and more patients, and you're basically painting the picture into this, is basically very high. So the major stakeholders who need to be benefited on humanitarian grounds, who for whom actually this is being made, the patients in general, they are opting out of conventional methods in the sense they are letting go of the access to all the benefits or to all the cure that your conventional methods were providing you. Now, conventional methods had certain side effects. They had not side effects, they had certain negative feedbacks, let us say, in different methods, in different ways. They chose to basically enter into this particular unconventional cure. The way it has been put forward, probability bias already exists amidst the patients. In majority, they don't wish to opt into this. The fact that we are giving them this right in itself turns this fact that clinical trials, which are highly regulated, when I say highly regulated, in terms of people who are selected, the age group, the kind of population that I would say, test it on, the kind of sample set that they would be working on, it is very, very scrutinized, it's very regulated. Now, when you give the right to try, basically opting into this removes transitioning into further phases of research. The reason being, these major firms, what do they begin doing? They are going to get huger sample sets. They are going to get it at people voluntarily opting in, even without knowing about it, right? Even when such situations occur, when the major medical firms are going to get higher sample sets, these highly regulated clinical trials, they are going to transition into a random experiment, right? You have people who are coming in and you're just testing it out on them. And the fact that they're opting out of conventional methods as well deprives them of the chances of, I would say, chances of bettering their life standards, the chances of surviving the benefits of the research that has gone for hundreds of years, right? So yes, so if we speak of what else they have put forward, conventional cure, it does no wonders, right? But unconventional cure, it just keeps you surviving. The solutions that you were getting from conventional cure, the bare minimum survival that you're going to be getting out of unconventional cure, there is no comparison, right? So yes, phase one clearance is hardly under 1% or something. The way they put it forward, that doesn't imply that phase two and three are going to get succeeded. The side effects cannot be removed, or you cannot say you're not going to opting out of conventional cure and opting into a experimental treatment. You cannot say
POI.
that is going to give you the autonomy. The power is not something that necessarily is going to benefit you. It is going to benefit these major organizations. And so yes, experimental treatment, if you want to give the right, it's basically equivalent to say right to pray in scope of treatment, right? You imagine saying, I am ready to
POI.
give myself off. Yeah, PY.
Considering that most of these clinical treatments and whatnot usually just happen in major cities and abroad, are you okay with the fact that poor people and rural people are just going to be excluded from these clinical trials?
Well, yeah, I do. I do agree with this. Cool. So, my major point is the fact that this has the likelihood, these major organizations, they have the likelihood of pulling in the audience who naturally can be used and not benefited. They don't necessarily have basically a legit stand to walk out of conventional treatment, except for the fact that there is a hope, a faith that is painted on their picture, is on a humanitarian ground ethically wrong. There needs to be clinically set up trials which are highly regulated, and randomly distributing the right to opt into these experimental treatments is against the grounds. Thank you.
I thank the Speaker for that fine speech. To continue the case for opening government, Deputy Prime Minister. Hear, hear.
Hi, this is DPM going in 10 seconds. Cool. Before I begin, can you just like clarify if like I'm supposed to do anything with the recording or it's like it's rolling?
No, it's rolling. Just go ahead
Cool.
when I'm ready.
Cool. Uh, cool. This is DPM. POIs after the 5th minute. Ideally from closing, cross engagement. Cool. Starting my speech in 3, 2, 1. Panel, please note that the opposition has no case in this debate unless they prove why the choice itself for the right to try itself is such a bad thing, right? They do not tell you at any point of time why this choice that we are essentially giving these people on our side of the paradigm is like so bad that that itself is like not something that you're supposed to have, right? Because please note, this debate is not about whether it's a good thing or a bad thing. It's about choice, right? It's about whether people should be given this choice or not in the first place. And we'll tell you exactly through this speech why this choice is incredibly important and why people at this particular juncture in their lives absolutely need to have this choice of right to try, right? Before that, then panel, please note also a fallacy in the case of the opposition. They tell you that how, let's say, if you're opting into this experimental treatment, you're essentially opting out of conventional treatment, which again is not true, because what this means is that conventional treatment simply did not work on you, and that's why you're having to get into experimental treatment in the first place, right? If conventional treatment did work for you, you would not have had to opt for this experimental treatment in the first place, which is a clarification that we need to set across for like across benches going forward. And that there is no point in assuming that essentially the people who are like opting for these experimental treatments are only going for experimental treatments, and they do not have anything to do with conventional treatments to begin with, right? It just means that conventional treatment did not work on them, and that's why they're opting for this in the first place. What is our burden then? Our burden is simple. Our burden is to prove why this choice is extremely important, right? As I mentioned in the first place as well. This choice is extremely important because at this point of time, please note, panel, that the absolute harms that this patient or this person who is at this critical juncture in their lives can have on our side is that at max, maybe they'll probably get like a few side effects. They'll probably like the treatment probably like wouldn't work to its fullest capacity, and like maybe like 100% of the treatment won't be effective, but then maybe like 70%, 60%, 80%, depending on like what condition that the patient is currently in and how the sort of like medication and like the treatment sort of works with them. It'll probably have like a success rate of like that particular level, right? Or maybe even if it is lesser, what's simply going to happen is ki these ill effects are just going to like maybe be a little higher on our side of the house, right? But then on their side of the house, they also have to prove to you that why, let's say, at these patients at this point of time, why opting for these experimental treatments is absolutely like lesser, beneficial to these people in comparison to, let's say, when they do opt in for it, right? They also don't give you any mechanization as to like what is going to happen to these people if, let's say, they do not opt out for this, if they, let's say they do not opt in for this experimental treatment in the first place. But we tell you that essentially, because like since this is like the last option that these people have to begin with, it means that the conventional treatment essentially did not work on them, and because it did not work on them, they essentially do not have any more options to go for in the first place. And at this point of time, this is the only fucking option that they have on their plate, and they have to absolutely take it because this is literally a do or die situation for them, right? If they do not go for this, then simply like they're probably gonna die anyways in the long run, or maybe in the short term, depending on the intensity of their particular ailment. But then on our side of the house, they still at least have a choice at getting better in terms of their health. They have a choice to make in terms of whether they want to opt in for this particular treatment or not. And I do not understand why having that choice itself is so harmful to begin with, right? If you in our world, if you still, let's say, do not want to opt in for this experimental treatment, you still can choose not to, right? If you just feel like I'm okay with my current situation, I'm okay with, let's say, the health hazard that I'm currently facing, I do not want to essentially opt in for this experimental treatment because maybe it can like probably make my situation worse. I still do not understand again why having this choice itself is so bad, which again opposition does not clarify for us in this debate, right? Because they do not tell you why this right itself, why this choice itself is so bad, why having why having exposure to this choice is so harmful. They essentially do not, they essentially can't take this debate across all gov benches, right? Moving on then, please note, panel, that essentially these clinical experimental rounds of like experimental treatments are still existing in today's world in the first place. It's just that the access to this hasn't been democratized to begin with, right? If people, let's say rich people who already have access to like a lot of resources, and they are getting their treatments done from like top hospitals in the world where all of this research is, let's say, taking place in the taking place to begin with, even like, let's say, even if they are not rolling out this particular treatment for like the masses or like for everyone's use, even if you, let's say, have exposure to these hospitals wherein these facilities are being developed, you will anyway have the choice to essentially opt in for these experimental treatments in that case as well. In our side, what we are doing is we are essentially democratizing this whole process. So like, even if so we're basically giving this common platform, common choice of framework for like everyone to play with. And why that is a good thing? That's a great thing, because essentially, like, something that has been restricted for a long time in terms of its access will simply be democratized, and people who let's say do not have much of these resources in the first place, who are, let's say, not going to these hospitals which are on the cutting edge of medical science development, they will still have access to this treatment, and that's why they'll be so much better off than their current condition. Before moving on, any POI? 3, 2, 1. Moving on then. So, panel, we tell you essentially how, in our worst case, patients will have, let's say a few more side effects. Even if the treatment like fails on our paradigm, op does not prove to you how sticking to the conventional path is going to assure success, is going to assure that this patient, let's say, is going to come out better in the long term. But on our paradigm, we tell you exclusive benefits which are only possible on our side, which firstly come in terms of choice, because we give this choice to the people that they can essentially, if they want to, opt in or opt out of this treatment. And secondly, it essentially gives them the last final bastion of hope in which they at least have a chance of essentially improving the current health condition that they particularly particularly have, and that option essentially does not exist on the other side, simply because the conventional path has anyways failed. If you do not opt in for the experimental path, your situation is just going to get worse. You're just going to die. You're just going to, like, probably get into, like, bigger side effects, or like bigger bigger conditions in terms of, like, a bigger intensity of conditions of, like, what you're facing currently. But then on our side, you still have a choice, you still have a hope of, let's say, getting your situation mended, and like getting your situation done better, right? For all these reasons, panel, Gov completely takes this debate incredibly proud to propose.
I thank the Speaker for that fine speech. To wrap up the debate for opening halves, Deputy Leader of Opposition. Hear, hear.
Yeah, I hope I'm audible.
Yep, you're clear.
Oh, works. Okay, for PI preferences, try to write POI in the chat. Yeah, I'll take one at some point in my speech. I don't really have a time setting. Do not under any conditions vocalize though. Please simply type it down in the chat. I will be looking. Yeah, preferably the POI is from, well, closing, but if that can't happen, opening works as well. Okay. I will start my speech in 3, 2, and 1. Okay, panel, the main problem in this debate and why I believe Gov just completely takes the fall is, one, they try to fantasize the sort of power of choice to an incredibly high degree, where it essentially has this point is turned into power tripping. I'll show you why the power of choice isn't necessarily the main metric in this debate, and why that's not really the most important thing to these people, and it's not also the most important impact in this debate in the first place. I'll also show you why the autonomy to decide your own fate isn't really as important as they seem to make it out to be, and why even at that point of time, they also would not agree what the results of this autonomy actually end up being. Then I'll try to dismantle their weird little numbers game regarding percentages of phase 1, phase 2, phase 3 trials, because they seem to have a completely distorted view of how those things work. Right. The first thing I want to tackle, though, is something which basically, like, this one sentence is the entirety of the entire DPM's case, which is experimental treatment is a last resort. The only way they would opt for experimental treatment is if conventional treatment does not work. Therefore, we are killing them. Therefore, Gov Bench categorically loses this debate, as experimental treatment can only possibly be the last option a person chooses. Therefore, you automatically win on the comparative. This is what Gov claimed. I'll dismantle this very quickly. First of all, the conventional treatment for cancer is chemotherapy. There are hundreds, if not thousands, of alternative clinical treatments for cancer with varying degrees of success in terms of phase 1, phase 2, and phase 3 trial, with varying degrees of clearance. At that point of time, people do not only take up these trials simply because chemotherapy has been, as they claim, proven not to work. And many times you can't even do that because chemotherapy clashes with all these experimental treatments. They can't claim that, and as we claim, we told you that conventional treatments on average and far in a very high probability clash with experimental treatments. You can't have them both coexist at the same time. Their argument was, no, you'll first have conventional, it won't work, then you'll opt in for experimental. That's not how it works, because chemotherapy does not have a set date at all. You can't guarantee that chemotherapy would or wouldn't work, even if it is the conventional treatment. But it has the highest probability of success. That is what we maximize. They put the burden on us somehow to prove that as long as they take the conventional treatment, they will survive. Understand, panel, this is not the burden on side opposition. All we have to prove to you is that on average, these people have a higher probability of survival than they do in opposition's paradigm. Right. Another important thing to break then is the arguments regarding why the only important thing here is a right of choice. We've already told you one thing, why if we do this, and the sort of regulations put on research firms and on medical firms will decrease vastly. I wanted to understand something. They seem to believe that experimental treatments are simply not allowed to be taken by people at all in status quo, and it's somehow in this weird place where only the rich and powerful and mighty, as they call it, can access them. That's simply not true. Experimental treatments which have achieved phase 3 validation can still be taken by patients. They can still act as people who are getting into these experimental treatments, and they can still try to get themselves better. These treatments have all of their data released. Patients know what they're getting into. The doctors know what they're getting into, because this drug has been shown to be effective to a certain degree against the disease. It has been shown to be effective to a certain degree against conventional treatments over this disease as well. Understand that when they come in and tell you that it's like the only bad thing which can happen is they kind of become slightly better. What is phase 1? Phase 1 guarantees a safe dose. That's all phase 1 guarantees. Phase 2 is what determines if it even works against the disease in the first place. Phase 3 determines how much better it is against the disease. Phase 2 and phase 3 are fundamentally more pivotal. I'm not going to play a weird little percentages game like the OG first speaker wanted to, but it's incredibly obvious simply by looking at the different descriptors of what each phase entails that phase 2 and phase 3 are significantly tougher to clear than phase 1 could ever be. This is another incredibly big problem. Even in our status quo, you can tackle experimental treatments, but they've been guaranteed at least to work against the disease with varying degrees of success. In their paradigm, you can just take any experimental treatment you possibly want, and there's no real requirement for the research firm to show that it even works. It's not even required to show it's better. They don't even have to show it actually works. Right. Understand that when they try and claim that these people are actually going to be better off because they now have autonomy and they now have hope of survival, I want you to understand, panel, hope of survival also exists in conventional treatments. Once again, which I clarified in the very beginning of my speech, patients will not only opt in for experimental treatments if conventional treatments fail. It is not a pipeline which goes, I try conventional fails, I go to experimental. This is not the pipeline which generally happens. Patients look at conventional treatments, they look at probabilities. Conventionals often clash with experimentals. They either choose experimental treatments at that point of time, or because they're afraid of the sort of pain they'll have to endure within conventional treatments. These are the mechanisms which largely drive the choosing of experimental treatments. It's not that, well, I'm gonna die anyways, I can only really choose this, because that voluntarily is just not something which happens in the first place, right? Also understand that some of the points which came in the first speech were like they don't rely on people because experimental treatments are done by them themselves with their MD degree. They also somehow get autonomy, which they don't get in conventional treatments. Experimental treatments are generally much more restrictive because it's not been defined yet how they're actually going to be functioning, because the research hasn't been conducted properly, because many things are unclear. I fail to see why autonomy exists on their side of the house anymore, or in fact, not just significantly less than it does on our side of the house. Another argument was their family thinks they tried. Once again, are they not trying if they fight against the conventional treatment? Is that not trying to fight the disease? I fail to understand why any of that was ever relevant. Yeah, any POIs before I move on? Yep, I'll get 3, 2, 1. Yeah, okay. Moving on. Understand there's 3 kinds of people. A POI which we got, which I'd like to clear up very, very quickly, is that are you okay with poor people being excluded, right? Which means that these people seem to once again be holding the misconception that only the rich and mighty actually get into these experimental trials, and therefore the poor people never have a chance to access them. First of all, experimental trials are not free. It's not like they're charity. Even if you tell a poor person about an experimental trial, if he does not have the amount of money or resources to satisfy these medical firms are giving them out, it's completely symmetrical. The only difference is he now knows there's something that he can't possibly attain. That's the only thing you achieve. Even without that symmetricization, understand that at the end of the day, when these poor people, etc., are being told about these experimental trials, they may completely be coerced. They may be coerced by the doctors. They may be led astray because they don't understand. The doctors who might themselves be running clinical trials may force them to become people in their own clinical trials for free without paying any remuneration in the first place. To end my speech, I'll discuss 3 kinds of people. I'll show you why we win on each of them. People who know about these trials and who are well aware about what these trials entail. These kinds of people are symmetric on both sides of the house. People who somewhat know, who have superficial information. People like this are likely to make bad choices for their own futures and significantly harm their own health, which we stand against. And also this affects the sort of research firms, which I already told you before, the regulations and how the data set itself gets tainted. And then the people that don't know, we've already shown you that for the people that don't know, it's the most harmful because they can be coerced, they can be led astray, they can be turned to the side by at any point of time by the doctors, by the researchers who are actually working on these things. We win on all 3 possible kinds of patients. We take this debate in stride. Thank you.
I thank the Deputy Leader of Opposition for that fine speech. To open up the closing halves of this debate, can we have Member of Government? Here, here.
Hi, just give me a second. Okay. There will be a point in my speech where I open my debate up for POIs. So, with that being said, starting my speech Right. Starting my speech in 3, 2, 1, go. So actually, let me start off by rebutting what opposition has come forth and said, right? First of all, let's understand that patients that are actually coming for this right to try is they've already failed standard treatments, right? That can't be negotiated, right? Understand that nobody's actually choosing between a working treatment and an experimental one, but what they're doing is that they're actually choosing the probability between the probability of death and a chance at survival, right? So understand that in this case, the highest probability treatment means that it did not necessarily work, which is why patients are already looking at the right to try, right? Understand that our mechanism actually does include some sort of medical guidance and does not remove standard care in any manner, right? Understand that the right to try does not override this very thing. Patients and doctors are still given that very choice, right? And it becomes a legal option once this very conventional path is exhausted or when it is no longer effective, right? Doctors and not just these patients, they're basically going to obviously guide these very decisions, right? Meaning that patients aren't just doing these things on their own, but they're basically trying to do the best possible thing, and they're guided by doctors that actually have the experience and knowledge, right? Furthermore, understand that chemotherapy that was brought up by the opposition, that is just one example, right? There are diseases that for which the care is either inaccessible or not really there, right? Something as simple as ALS, there is no necessarily effective standard care, right? So in this case, experimental treatments basically become the only promising option, even if it is still in the pipeline, right? So when you refuse patients to actually try such treatments because they haven't necessarily reached phase 2 or phase 3, it basically punishes those with those rare or poorly researched diseases, right? So why are these patients likely to be saved in our world, right? We unlock these treatments earlier, and this is particularly relevant for rare or fast moving cases, right? Some patients die during clinical trials because the drug is approved too late, right? But what we come here and tell you is that when there are treatments with proven safety, they become accessible faster, right? And this is critical in diseases that do not necessarily wait for time, right? Something as simple as a brain tumor or something as simple as ALS, where trial timelines do not align with what the patient's timeline is. So this time margin, in fact, saves lives. Now, what we come here and tell you is that our world is actually more inclusive, right? When you look at the opposition's world on the comparative, there are poor patients, there are rural patients that don't necessarily get that chance to enter trials due to various reasons. Their only option is to basically wait and die, and they are not included in the opposition's quote unquote higher probability group, right? In our world, what we tell you is that these people get the access through the right to try because they do not have any other option. And that has already been established as to why, because this is the last resort. This expands the number of lives that can be saved, right? And there is no limitation whatsoever. So what is the comparative? We come here and tell you that there is access post phase 1, that there are safeguards in place, that there is still a regulation in place because doctors are guiding people with their decisions. Patients are able to act within specific time limits, and more importantly, these are people with rare diseases actually get a chance, right? These lives are saved by some sort of by inclusion speed, and there is a feedback loop as a result because they learn what is right and what is wrong so that they can do better to actually help create innovative things, right? Understand they also bring forth the very thing of cost, right? But first of all, understand that costs will more often than not exist in both worlds, right? But there is a reason for why ours is more equitable, right? Because even if a drug is life-saving, you are not necessarily going to be allowed to access it unless you're in a very trial which has some geographic health filters, right? If you're poor or if you live in a specific area that is far from a trial site, you will have no access at all. So what RTT does, like what the right to try does, is that it basically gives you this route to access. It gives you a legal route to access, and it makes it possible for stakeholders like the government, NGOs, to actually step in because it is no longer banned, right? So what we tell you is that our model or our world is basically enabling some sort of policy intervention that allows such costs to be reduced. How is that so? Because you look at governments, they look at these treatments and they say that they can more often than not subsidize these things. They can regulate pricing. They can do better as to lower such prices. Because when you look at the right to try, pharmaceutical companies get real world data. They get an idea of what the patients feel and don't feel. They may offer early access at certain costs. And furthermore, understand that cost isn't actually a reason to ban every hope, right? That does not justify banning access. If you have 10% of patients that can be helped now, and if that number will essentially grow over time, it should be started now, right? That is not a good argument at all. Now furthermore, I want to talk now, the government comes and talks about why this choice is not bad. I'm going to tell you why the opposition's world actually leads to unregulated or more harmful outcomes, right? Understand that what happens when you're sick, right? You are desperate to be better. Understand that this desperation does not disappear in their world, right? Terminal patients do not accept death, right? What happens is when they are denied access through the legal system, they're obviously likelier than not to turn to maybe black market drugs, unlicensed drugs, unwell medications, right? verified treatments, right? And these are completely unregulated. There is no oversight that is there through physicians or doctors, and there is more of there are higher risks than drugs that have been cleared by phase 1, which have already gone through some approval, mind you. Furthermore, this is creating some sort of inequality in the market, right? You look at these patients, there are wealthy patients as well that will hire good doctors, good lawyers to access these drugs through loopholes, right? And then you have poorer patients. They are basically patients that are marginalized or come from different backgrounds. They are shut out. What happens? There is no option. There is basically some sort of, there is even a possibility that they do self-medication through some online sources. So what happens? This system is more often than not rewarding privilege. The opposition comes here and says that they are defending safe speech, but that is only if but we come here and tell you that their world only looks like they're basically defending the rich, right? Before that, POI, you can like open your mic in 5, 4.
Yeah. Okay.
Yeah.
Regarding the POI, how do you handle all the drugs that are now accessible to these patients that would originally have like drastically failed phase 2 and phase 3 trials?
Could you rephrase that?
Yeah. What about all the drugs that the patients can now access, which would originally have completely failed phase 2 and phase 3 trials in
Okay,
your paradigm?
right. So, like I've said, there is already regulations in place for this very thing, right? When they look at these drugs that might have failed specific phases, there are doctors, physicians that tell them that, oh, okay, fine, this might have failed a specific phase, but we tell you that this research, there is a likelier chance of you to actually be cured through these very things, right? So, what we're telling you is that there is already regulations, that there is already a mechanism in place to actually prevent people from taking decisions that might potentially fuck them up, right? So now coming back to my whole thing, right? That opposition world with the unregulated system, right? What happens, right? You see that there is trust that is more importantly destroyed, right? You look at a potentially helpful treatment that exists, that is past phase 1, but it is being denied by regulators on certain principles, right? But what happens as a result? Patients begin to distrust these doctors, right? And they basically turn to different things, as I've already established, right? So what happens over time? There is lesser confidence in the legitimacy of these regulated things, right? Now, furthermore, what I'm telling you is that RTT will actually take these experimental uses under oversight. Understand that we channel this very reality, right? Because understand, we've all established patients will pursue these experimental treatments either way, but we channel this through licensed physicians, through some formal consent protocols, through phase 1 data requirement, through different medical institutions that talk about mandatory reports and so on. We don't necessarily invent this very demand, but we ensure that this demand is actually met within some certain medical oversight, right? And with that, I'd like to rest my case.
I thank the speaker for that fine speech. To begin the case for closing opposition, can we have member of opposition? Here.
Hello, am I audible?
Yes, you are.
Okay, I'll begin on my first word. Just give me a second, testing some things. Okay, I'll begin in 3, 2, 1, go. Panel, the most cruel thing you can do to a man with very little is to cheat him of anything he has left. In closing opposition, we will prove to you why this right to try surpasses the threshold of harm caused to the individual, which requires us in society to ban this particular right from existing. Notice often we ban the right to choice anyways when we ban people from speaking things which are religiously insensitive because of the harm it does to society. When we ban people from taking some kinds of drugs because of the amount of significant damage it does to the body, we will aim to prove that this right to try also satisfies these requirements. The first thing to prove then is why the right to try creates incentives to push incomplete products to the market, right? For 3 reasons. A, this becomes a very cheap source for testing for product making companies. Why? Because you don't have to do your own drug trials anymore, where you need your own equipment and you need your own monitoring and you need your own employees. You get this for free on-site government when you can do this directly in hospitals, which means you have more of an incentive to push drugs and test them in hospitals with real patients as fast as possible. But also under this, you notice you have gathering your own patients is extremely difficult on government side, on opposition side, because you have to pay them for coming to your trial. Versus on the other side, patients pay you for taking the drug, which makes it much more cost efficient and things like that, right? But B, notice it allows you an increased ease of business. Why? Because of things like getting first mover advantages. When your products are flooding the market faster than other products are uniquely solving a rare problem that nobody else can, you create things like brand loyalty much earlier, which is an extremely powerful business advantage that firms are necessarily trying to get. But also, it looks like bypassing bureaucratic bureaucratic hurdles that allows you for faster recuperation of research and development costs. That is, I'll push my product as soon as possible to the hospitals after phase 1 and things like that, because the faster patients take it, the faster I can recover whatever expenses went into making it in the first place, right? But see, notice we've lots of media exaggeration when these trials happen, right? Because the media has an incentive to magnify this exaggeration and the effectiveness of these things because of market competitions, because they have a 24/7 news cycle to sort of cover with all sorts of newses, but they don't really have as much, which means they take small news pieces and make them sensationalized to get audience, which looks like taking this one small drug trial and say, oh, new groundbreaking trial that does XYZ things, but also looks like getting more clicks in social media and getting more views on TV, which means discussing these things with an exaggerated point of view, which ultimately leads to an environment of increased market competition and a race for the media narrative dominance by these companies, which is also leading to a race by firms. What all of this means in this debate is you have a highly expensive and a whole lot of dud products in the market which claim to satisfy all these kinds of conditions, right? But also on this front, notice we already preempt this argument about black markets from closing government, because at a point where it is so expensive to make products without this right to try, it does not make sense for the business model of these companies to be going to the black market to sell them, because it will not be profitable to have this happen. Rather, what actually happens is black markets become unsustainable and these firms are forced to go through regular regulatory pathways and make products and profits on the long run. The second thing then I want to prove is why this existence of huge number of expensive dud products is extremely exploitative, for three reasons. A, because it's extremely expensive. You have extremely high R&D costs which you just have to recuperate. There's nothing you can do about it. But also B, you have lots of desperate patients who want to take this, which means there's a high demand from these patients for it, which means you can price these things to a high degree, because you know patients will do anything, whatever, with sell their liver, whatever, to get these kinds of drugs.
POI.
But also under that, you are necessarily are not even covered by insurance in these patients, because insurance doesn't really cover a lot of these experimental drug trials. Ultimately, this means these things are extremely inaccessible to a large amount of poor population, which side government keeps yapping about, which means they don't even access it on their side, so that benefit does not exist. But also to even middle class and richer audience patients, it takes away a significant chunk of the wealth to do this. But B, even these health consequences are sort of existing even after phase 1 trials. Why? Because you have long-term side effects that remain undetected after phase 1 trials. Phase 1 trials have probably a duration of 2 to 3 months, but some side effects can take a year or 2 years to show up, which can be damaging and even chronic. But also you have sample sizes of diversity in phase 1 is really low. Why? Because you have lack of access to health institutions by minorities for them to participate, but also they're just even rarely approached by academics because their inclusion in academic spaces itself is really low. So you don't know how this drug works on bodies of minorities, bodies of women, and things like that. But just finally, you have randomness that remains a factor. You don't know how this drug will perform on the random patient. But finally, see, you sign away your right to recurse when you do this kind of experimental trial, because you sign indemnity waivers to waive your right to prosecute these kinds of people in case something goes seriously wrong in your trial. Ultimately, what does this mean? That there's a significantly high amount of damage that can be done to the financial, psychological, and physical well-being of this person if you do this kind of trial. Yes, the question then is, even if there's a 99% chance of harm and a 1% chance of success, why can't people opt in choosingly into the 1% chance of success? Two things. First of all, people don't automatically assume that it's going to be a 1% chance of success. People have a positivity bias. They have a reinforcement of positive thoughts coming from families and friends, and they have their own hopes and things like that, which makes them think that it's probably going to be a higher chance. Why is this important? Because it only becomes a valid choice if they are informed and are aware of the extremely low chances of the kind of drug sort of working is, and the kind of damages come along with it, which leads to my third burden, which is why this is actually an extremely coercive practice. Notice when offering these options, doctors won't actually know which experimental drugs will work. Why? Because these drugs haven't been in the market that long, so they don't know all the effects of it and the successes of it or the failures of it. But also, new drugs keep on coming, so just too many to track, which means they just have to rely on the kind of data they're getting from the suppliers anyways. But finally, working for one patient in this drug doesn't mean that the same drug will work for other patients, because there's a lot of unknowns. You have different body compositions, different hormones, and things like that, which means that the doctors are just not in a position to be able to create information for the patients in a way that they can understand the importance and the dangers and the tribulations of this drug trial process, which means they end up recommending lots of drug duds to patients. Yeah, POI. Okay, nothing. So
Considering
finally,
that companies
yeah.
put money into R&D anyway for new treatment mechanisms, I don't understand why the black market is unsustainable, because they anyway have this drug in development to begin with, right?
the black market is unsustainable because you're not going to get significant volume from the black market, because at a point where you're getting like one or three customers because it's extremely regulated and very few can bypass it, what happens is you necessarily can't develop drugs for the purpose of going to the black market, which is why you don't develop these drugs in the first place. You rather go in the long term and develop safer drugs and go through legal channels. But now this finally explaining why this is coercive to the patients, and everyone agrees with this, right? As a patient, this is probably the rarest and most chronic of illnesses you've suffered from a long time. You've tried all other previous treatments and they've all failed, and they don't even slow down your condition. You have strong emotional attachment to the idea of being free of illness. It's your dream, which means an extremely high degree of desire of getting the illness gone, which means you're more highly exploitable. And this is exploitation, which is the difference between a choice and exploiting, because the pharma companies that do this know it's not going to work as much. They know they're doing it just for making a profit, and they know the significant damages that are done to the patient, which we do significantly better job than opening opposition and proving, and we mitigate all the harms that comes outside government bench. For those reasons, vote for side, closing opposition.
I thank the speaker for that fine speech. To conclude the case for government bench, can we have government whip? Here.
Hi, just 20 seconds. Sorry. Okay, starting my speech in the count of 3, 2, 1. PO is vendor, I'll take the best. 3, 2. Okay, firstly, to get this out of the way, a few areas of rebuttals. First off, the aspect of insurance coverage is not unique to right to try, right? It's already common in terminal care, right? Because most cutting-edge treatments aren't covered immediately, right? Because at the end of the day, end-of-life treatments already involve out-of-pocket costs, travel, special scale. It's not about the right to try problem itself. It's a structural flaw in the insurance system itself that in that case doesn't even stand in the first place, because you can't blame the right to try aspect for a healthcare system that is already denying care to her dying people. Number one. Number two, at the end of the day, we know that the right to try access is already being subsidized in some cases, right? Because it terms at the end of the day, it's a compassionate use case, right? Why is this the case? Because now hospitals are going to absorb these costs to gather early data at the end of the day. They're going to just give it to pharma companies, so it's going to donate doses to trial patients to actually build and trust safety records, right? Because at the end of the day, patients are not always paying, and in many cases, pharma has more reason to fund the charge, right? Furthermore, insurance not covering it doesn't mean actually no access, right? It just means it's not standard policy in the first place, right? Because why is this the case? Rare disease patients, oncology patients, like Pranav has already come here and told you, they already use crowdfunded, self-funded, or use foundations, right? That's already common for clinical trial travel or off-label use of rare medications. And right to try just normalizes and legally opens up that particular aspect of access. And furthermore, people are already paying to live, right? At least now they can do it legally with medical support or potentially subsidy. Second up, coming to the aspects of yeah. So next up, let's talk about what exactly have we brought you inside closing opposition, right? Silva said closing government, right? What have we told you? We've already told you about how these patients are in the healthcare system right now, right? They're already abandoned. At the end of the day, right now, we have these government hospitals and hospices and palliative care where all these terminally ill patients are usually there, where clinical trials themselves is going to be a hard thing to access for these people simply because they're either poor or they're rural networks, and where these trials do happen around all the large cities. At the end of the day, it is going to be a huge problem. We come here and tell you that honestly, on our side of the house, when you're opening up the right to try as an aspect for these people, we'll at least be able to do something at the end of the day that at least gives them not just an aspect of hope, but also at least for giving them that aspect to at least try something. Because we've already told you through our analysis that it's not a last option, right? It is not a last option in this case because there are these aspects of things. Because what we're essentially trying to push to you is that we're going to make it in the sense it's not exactly going to be any sort of completely thing, right? Because at the end of the day, what we are doing essentially is just that we're giving them systemic reform, right? We don't delay something good because another system has caught up. We're just creating legal access and then fighting for some sort of access to it. Furthermore, coming to the closing opposition's demands about these unsafe products being pushed out in the place. First of all, phase one is not incomplete drugs that verified safe for human race. They explicitly test for safety dosage. No one is asking for access to completely understood drugs, right? They've already been tested in clinical environments and regulatory oversight, right? They're scientifically validated. Furthermore, we've already proved to you by our analysis that in the alternative, there's going to be unregulated drugs going into the black market simply because by the own closing opposition even continues to this point because they're telling you that yes, people are desperate at the end of the day. And when people are desperate, they turn to measures that there can be a Hail Mary at the end of the day. They don't care what it is, which means they are more likely to go into untested markets on both sides of the world. That part is essentially symmetric. Furthermore, let's consider this, right? Regulatory oversight doesn't disappear under the right to try, right? Because now drugs are going to, because how does this work, right? Under the right to try, essentially what we come here and tell you, we've already told you that these drugs are going to be given by these pharmaceutical companies they're also going to be regulated for manufacturing quality, and if the doctors still exist, right? They're going to perform informed consent, follow dosage guidelines and side effects. It isn't a free for all at the end of the day. What we are essentially telling you is that it's a tightly controlled exception under numerical guidance at the end of the day, right? Furthermore, there is no commercial incentive to push these unsafe drugs. Why is this the case, right? Because drug companies are at the end of the day have always been risk averse, right? Because no company wants a lawsuit from any sort of adverse reaction, right? Because at the end of the day, they offer an unsafe or a rush drug that's just going to hurt them more than actually waiting for it, right? Right to try doesn't make a business sense for an responsibility in the first place. But furthermore, what exactly do we do that is better than the other sides here, right? We've always been pushing towards you from this entire case on-site closing government that what we've always mentioned that without the RTTPA, we've always been saying that we don't allow full approval at the interview, but there is a conditional access. There is no front gate access. And the status quo is already allowing some experimental access, but we are just formalizing it. Now, all that we've been hearing from side opposition on this debate is that the cost and regulation, right? One, we've already counted these mechanisms. We're talking about how there's going to be a regulation on both sides of the house at the end of the day, because one, pharmaceutical companies are just going to start pushing out stuff because for the lawsuit. Furthermore, doctors are there for a reason, right? But furthermore, what else I've been telling you, right? We take this debate over government in the first case because the government's entire case is about choice and hope at the end of the day with a little bit of access of probability care. What we do is actually we recognize these harms and we tell you that why people are just going to be worse off the alternative on the other side of the paradigm. Furthermore, we're also talking to you about how there is going to be these access to capacity, how there is going to be a latency, right? Understand, we've already told you that these poor people are going to have difficult access to these drugs. But why is this the case, right? There's already these access to these early stage of these drugs is only available to these elites that is going to be there through these under-enable arrangements, right? We have been, what our framing or what we've been pushing to you is that the right to try is not an attack on self, but it's just a response to this sort of entrance inequality and gatekeeping the first. But furthermore, we've also talked to you about how in this world people just going to end up turning to homeopathy, spiritual, or some sort of being failed by modernism, but just giving them a scientific experimental route because at the end of the day, they just we're just saying that deny the right to try is just going to increase the risk because now people are just going to pursue options, just regulated ones. I'll take a POI. Anything in 3, 2, 1. But furthermore, what else have we been pushing towards, right? We've already told you that these regulatory bodies, how are they, right? They have the existing status quo, they're already understaffed or any sort of this thing, right? And they're going to cause delays in approval even for promising drugs on that side of the paradigm, right? Because, but even if, for example, any drug that passes phase 2 or something, this is they're going to take years to be considered on their side of the paradigm, and people are going to die, right? Because not because the drug doesn't work, but because the paperwork stalled, right? Because so what is it that we've been pushing towards you? We've been pushing towards you that there is going to be regulation, and at the end of the day, what we're going to be working on is systemic reform, right? Because there is not going to be a floodgate effect. What we're simply trying to push forth is that there is the actual point here is not about the system. It is about the system in the sense that there's insurance. There are all these mechanisms in play, right? We are arguing that there are regulatory frameworks in play for this very reason. But on their side of the paradigm, they completely ignore this aspect of things and are proceeding as if there is nothing in place. And at the end of the day, this is just going to be a huge reason. It's a very extremely different case. Essentially, what we are trying to prove on our side of the paradigm and why we take this debate is that we prove that the alternative is extremely bad on the other side of the debate. We're actually opening up a legal avenue for people to pursue, which is going to significantly reduce the harms on their side of the paradigm. Furthermore, we've also proved to you that this insurance aspect and the aspect of things where incoming products are not going to exist as proved with said closing opposition. That is not going to exist on the paradigm. We've already given the answers. And essentially, that's why we take this debate. So, yeah.
I thank the speaker for that fine speech. To conclude round 1 for us, may we have Archit here.
Yashu, you're muted.
My bad. I want to make this debate extremely easy for you to judge. The first thing I want to point out is what exactly are these medicines that talk about when it comes to the right to try. Notice that they've cleared stage 1, which is establishing a healthy dose. But this doesn't mean that it's a successful with regards to ailments, nor is this something that actually is beneficial for the person. At best, this proves ingest or administer this medicine. This is not going to currently cause observable effects to be This is crucial because what this does is say, at best, things that happen on their side are things that don't fuck you up right now. The issue is there's a reason why phase 2 and phase 3 is in place. It's to completely rule out the possibility that those sorts of side effects don't end up accruing in the long term. The reason why this is important is because people that are often suffer from things like terminal disease often have significantly large and myriad varieties of underlying health conditions in the significantly weaker immune complexes. They probably have a lot more congenital conditions that end up interfering with other sorts of medical conditions and medical treatments in the first place. Stage 2 and stage 3 of medical testing often decides how a lot of these experimental medications interact with these sorts of cross-sectional medical terminology place. We think this is an extremely crucial part of medicine because people don't experience diseases in isolation. They experience it in reality in the multiple complexities of their body in the first place. Side government has to bite the bullet that they don't have the understanding of how their experimental treatments actually end up interacting with their patients in the first place in the long term. At best, they can say it won't kill them anything beyond that. So I want you to take this to rule out anything on site government as to why this is safe for a practice on site government. The second thing is as to, oh, there's probably going to be regulation and things like that. I want to note that if regulation probably exists, it's far better for like companies to engage regulation that already exists because it's something that they've probably already built their corporate and business but secondly, if their complaint is that, oh, regulation is slow, it takes time, and it's bureaucratic, but their solution is to bypass one stage 3 of trials and then introduce more regulations on how the right to try actually works, I'm unsure if they actually end up getting their benefit in the is the claim that, oh, this gives you a legal avenue to try to live in the first place. Notice this is exactly what causes the downfall of this. Because the legal avenue means that pharmaceutical companies ensure that their documentation is in such a way that they claim no legal liability for anything that goes wrong. This is exactly why they do things like make you sign indemnity waivers in case something goes wrong. They make you sign away your right to prosecute if you do go ahead and screw up anything. Note this takes away any sort of accountability away from them, which reduces the incentive for them to do anything like incorporate feedback or whatever that side government was talking about. We think they have an incentive to go ahead and do this because on their probably going to be less regulation if they want these products to be deployed faster and they want more people to try them in the first place. Because what this means is then businesses are able to engage in practices like altering their drugs that probably provide profound short-term effects because they know these are probably terminal patients and probably the end goal is certain death in most instances anyways. Is just what seems like the most effective drug is probably the most publications in the medical world, the most reputation, etc. We think this is backed by like intuition and like real world examples as well. Look at what Purdue Pharma did. Look at how they actually lace their medicines with opioids to ensure. We think at this point we don't think that pharmaceutical companies are the best actors within this debate, and they don't really care about actually works, whether the people actually heal. But what is the baseline of our case? And why is this independently winning against anything that Gov says, oh, they deserve the right to try? The basis for the right for anything and why we don't support rights in most cases is if it causes significant damage to either people around you or if it causes significant harm to the way that you live your life with dignity. Examples of this are already given at Archit, but I want to explain why this is uniquely the case for things like the right to try in the first place. One, in terms of the uniquely exploitative and the desperation that governments themselves characterize you are in the first place. What does this do? This means that any decision that you take isn't even if informed, isn't weighed in the proper calculus. It's weighed with extreme amounts of emotional irrationality and something isn't a wise choice that you can take. What does this mean? Is this means that you overlook the things that Archit talks about. You overlook the fact that probably this ends up bleed out from your financial savings a lot more and your family's financial savings a lot more. You overlook the fact that this probably means that something could go wrong later and you any way to seek any sort of help or recourse. And after that point, you're just at an even worse position, all because of getting that 1% chance to survive. At the end of this, I want to weigh this 1% chance against presumably you dying earlier at our worst case over here, right? Why is death not worth it? Why is the 1% chance to life not worth it? I want to know, panel. Death is the most certain thing for any living creature, especially for someone that's been living with terminal disease or probably suffering to the point that they want to seek experimental medication. We think death is something that they probably can't avoid. But what Gov does is it sells them a dream that they can't fulfill. Before I complete this weighing, any POIs? None. Why is this? Why is this uniquely bad? On our side, when they aren't being sold a dream, try, and when they know conventional treatment has worked, they have the time to be ones to find closure in what's coming for them. This means that they're far more likely to be accepting of the fate that they've been chosen. The fact that they tried everything, they tried their best, but things were not meant to work out. They're able to go ahead and opt mindsets of, oh, this day was probably coming. I want peace with my family. I want to die in the embrace of my loved ones, and I want to die in peace, knowing that I tried what I could. On their side, they're stuck in a rat race where they keep on trying experiment upon experiment, things that probably don't work. They get even more discouraged when they don't see signs of progress. This puts them through immense mental turmoil, which probably worsens their suffering far, far more. We think in a world where these people side government just compounds their suffering a lot more. We give them a chance to live their last moments in peace, grace, and dignity. We think this only happens if you don't support the right to try. For all of those reasons, vote closing opposition.
Lunch, feel free to ask me after, or feel free to drop me a message in the Discord chat if you would like feedback. So I'm going to structure my OA as follows. First, I'm going to give a couple of pieces of general feedback, the call, and how I came to that call. So 3 things for general feedback. I think the first thing we would like as a whole is to see less rhetorical assertions and more proof or development of your ideas. So what I mean by this is that there are a lot of points in this debate where, as a way of calling out the other side for having inadequate explanations or a lack of reasonable comparative, you guys say things like, there is no reason whatsoever to think XYZ, or you go, or you go as a point of rhetoric, but they have no mechanisms whatsoever. So I'm not gonna go through all the specific instances of this. I'm sure you might be aware of this. I understand it's a point of rhetorical emphasis, but I think actually explaining why this is not the comparative for like 3 reasons is going to be much more helpful for us in terms of assessing mechanistic contributions to the round per se. The second point of feedback that would be really, really helpful is if teams would weigh up the likelihood of their claims better. So there were multitudes of clashes in this debate that existed in terms of how different stakeholders might behave. So for instance, 1, do doctors advise patients to do what's in their best interest, or 2, might doctors be co-opted by pharmaceutical lobbies to be able to do a certain thing? So I think both of these things could potentially be true, right? Like if this played out in the real world, we would have some doctors who did one and some doctors who did the other. In terms of analyzing why a specific stakeholder behaves in a given way, it's helpful to weigh up on likelihood why more of them are going to behave in a certain way, or maybe, I don't know why, if a few of them behave in a certain way, that's still really, really bad and an outcome that we should care about. But generally be willing to accept that stakeholders or other actors are not monoliths. They may behave in different ways, and weigh up the likelihood. That makes it much easier for the panel as a whole. I think the third thing that the panel and I agreed on is that more structure was needed in this round. The issue with debating in the BP format is that there are 4 teams. There's a lot of arguments, a lot of rebuttals, a lot of things going on. So to that end, using structure. So for instance, if you are in closing halves, doing direct comparisons to your opening halves, explaining where you are novel or more impactful or more different would be really, really helpful. Otherwise, again, you leave it up to the panel to decide where your extensions are novel or where they're similar, so on and so forth. So especially if you're doing things like a vertical extension, flagging out what's different would be incredibly helpful in much tighter rounds where we'd want to weigh it. So that being said, we have a consensus decision. The call is as follows. The first goes to closing opposition. The second goes to closing government. The third goes to opening government. And the fourth goes to opening opposition, with the opening halves being very, very close. So I'm going to structure the call as follows. I'll go through each team in order and explain how they beat the other teams and weigh up to the position that they do in the round. So the first is CO. CO basically wins this debate because they provide the most structural and well-mechanized explanation of why the existence of the right to try in and of itself is net harmful in the world, especially in comparison to the alternatives that they set up to exist. I think most importantly, CO is also able to bring in mechanisms of structural exploitation. This is where we see the mechanisms from member of opposition where they go, desperate demand combined with expensive and ineffective products leads to an environment of exploitation, especially for the poor and the minorities on whom these things are unlikely to be tested and more likely to have adverse effects on. I think a particularly valuable piece of mechanization from CO in this round is when they explain that patients are oftentimes compelled to sign away the right to recourse via indemnities, which weigh significantly above the material given from the other houses in terms of explaining why people might have recourse or why we might be able to address it later or why it might not be so bad. I think WIT specifically builds on this and explains why this is the specific reason why there's no incentive to do testing or improvements as CG would otherwise like to claim it was. This was a very important piece of mechanization. But more broadly and generally, I think first of all, the extension was comparative. So CO basically argued that allowing the right to try drugs creates media hype and commercial pressures, which worsen access and distort incentives for drug development. So when they say the media will cover it like 24/7 wasn't purely just rhetorical in nature, it also fed into a broader, well-explained idea of perverse incentives, over which companies bypass proper regulation. This was quite important to break the deadlock that existed in the rest of the round because Gov was you are going to be inherently like coerced by the fact that you're in a bad position, right? So you're not really coerced, you just really, really want to get out of it. And then OO was going, oh, but companies are gonna like lobby you. So how does that weigh up? So I understand that this might sound derivative of OO because OO says that big companies are going to lobby and coerce you to do this. I think CO adds more when they explain how this specifically occurs and they extend in terms of the outcomes of harms that accrue, i.e. via distorting incentives and also the indemnities. That's why people kind of recourse and also why it won't be improved upon, which is why I think this was a sufficiently new impact from what OO says. The next thing they do is that they also respond quite clearly to member of government's idea of black market and why the black market is worse. So the extension on the black market and your alternatives being something that's significantly worse, because CO is able to explain that the black market becomes unsustainable under the right to try model specifically, and therefore unsafe products are probably going to be normalized under the state in that regard, so on and so forth. Finally, I think mechanistically, CO has the best explanation on the clinical difference between phase 1 and phase 2-3. This was something that was quite lacking in opening halves, as I think rightly pointed out. OG to this regard gives me a bunch of numbers, unfortunately, as to how, will it be 50-50? Will it be 90-10? These numbers don't mean much to me because I don't think anyone can actually prove them. I need reasons as to why the risk is high or low for it to be something creditable in a debate round. So the explanation that I think OO also calls this out, but OO doesn't provide a sufficient comparative to the degree that CO does. So CO highlights that phase 1 just proves things like, don't like screw you up right now, and why the long-term effects, especially for things like congenital diseases, minorities, other demographics are ignored. So in summary, I think CO clearly beats the other teams this round in terms of framing the long-term structural harms, not just in terms of the drugs being bad, but why you can't improve them, and 2, the exploitative dynamics, which outweigh the speculative benefits of individual access that Gov Bench wanted to prove down the bench, i.e. the last resort and hope, because they prove why you actually kill people's hopes in the long term insofar as there's a relatively decent likelihood that's probably going to be very bad for you or just not going to work for you. The second team in this debate is closing government. So closing government is second because they do the best job constructively improving the government bench and directly engaging with and responding to opening opposition. So I'll flag out here why they take below CO later. So the first thing I want to note is that the CG framing around comparative regulation stands out. CG introduces the idea that this is not a world of like no regulation, but a world with some guidance from doctors, NGOs, governments, other organizations are likely to want to come in and improve access. Also, I'm willing to implicitly buy that this means that there is some degree of regulation or at least oversight in terms of what is great or what isn't great. I think CG also sets up a comparative of the black market where there's absolutely zero regulation, provides a far clearer choice than OG gives, and also significantly extends the harms that OG otherwise would have proven. Just the drug is bad for you. CG goes, the drug is bad for you, but there may be other drugs that are much worse, and you are much more likely to be able to access them. So CG provides strong comparative rebuttals to OO's rich-poor access claim, which is where OO argues that the right to try where they argue that the right to try democratizes access. Now I note that this was built in DPM specifically in the latter part of their speech, where DPM says rich people will have access. Now we get everybody access. I know the idea was there, but I think it was too simplistic in the sense that I don't know why it's rich people getting access specifically. OG went, well, because they can access these hospitals or these like top doctors. But at the very least, I think this gets a decent amount of response from OO, though I still think OG edges out narrowly. But I think OG is better able to respond significantly to OO in this regard, where they structuralize and explain the mechanisms via which access is improved, i.e. the whole stuff on NGOs, governments, charities, so on and so forth. They also add this by explaining that wealthy people like have via loopholes as a contrast to make this mechanism work, which was also additional stuff that was quite useful given this claim from OG was under-mechanized in that regard. Now they also extend OG by clarifying that patients often die too late for treatment, which makes access timely matter. So the emphasis on these are drugs for which there is no cure also strengthens the moral framing, though I note that this was not as important a contribution because this was something that OG did already provide. So in summary, while they don't beat the structural harms that CO is able to prove as a result of this model, I think CG gives some much needed mechanization, direct responses to OO, and in terms of better mechanistic explanation to prove why OG's benefits do accrue, because while I think OG reaches for the outcomes, I don't really buy the degree of mechanization to which OG provides, and I think CG fills in this gap quite nicely. Next on OG, and this is where I'm going to flag out how OG takes over OO and why opening halves are below closing halves in this debate. So I would note that OG provides a pretty decent starting point for this debate in terms of they hit all the right ideas and outcomes, but I think they lack the structure or comparative clarity that CG is able to bring, as well as CO's preemption on harms. So OG basically centers the case around hope, agency, and the psychological benefit of trying rather than nothing. There are also points about how it improves, like, say, your sense of stability within your family because they see that you're trying, so on and so forth. They explain that patients will want to risk it and it gives them back self-respect and self-sufficiency. So the most unique point that OG brings to the table that we haven't already discussed is the point on people falling into probability bias, but I don't know why this whole people may potentially fall into probability bias justifies a systemic shift in terms of policy and this like radical new thing that we're going to necessarily push for, which is why I think the case from OG lacks mechanization on why the right to try solves uniquely the issues that presently exist, i.e. that conventional cures that already exist, but why are they, for instance, not good? I think OG just gives me examples in this regard. CG builds it up significantly more, or why they are practically unavailable. I think importantly, CG is able to clarify the access mechanisms, which OG doesn't, as well as respond to OO with regards to a significant number of other points that will be brought up later on. I want to note that the rich-poor access point was not determinative of the OG-OO clash. I think what was indeed determinative is in terms of proving in which side this likelihood is going to exist. And that goes to the feedback that we mentioned earlier, right? There might be a clash, right? Like people feel coerced via the situation and we have to give them a last resort. And then OO goes, but pharmaceutical companies may also coerce them. So people could be coerced internally and also by exogenous factors. And in that regard, I think OOG weighs up slightly more to the average intelligent voter. But here's where OO comes in. I'm going to specifically explain why I don't think they win that whole rich-poor clash, or why it wasn't so important to opening halves. So the reason why OO takes a fourth is because while OO does indeed flag important harms that exist, i.e. the ideas around false hope, coercion, or poor regulation, I don't think they mechanize or prioritize these harms in a way that wins the round. So the strongest claim from OO is that patients are going to be coerced by circumstances and coerced by pharmaceutical companies, and that experimental treatments are not actually effective, i.e. even if it's a healthy dosage, it doesn't mean no pain or no long-term side effects. But the reason why OO loses this is because they don't explain why this model is worse than the status quo. So when OO goes, people are just going to be brainwashed. People will just have superficial knowledge. Okay, but again, I don't know how this is going to be worse than the status quo. This feels relatively assertive in nature. I think OG is still able to prove that OG, for instance, I don't agree that they get their complete outcomes of people are completely cured, completely happy, completely restored, i.e., the whole regaining complete self agency and self sufficiency. But I do think OG proves you have a slightly better chance at survival where there otherwise wouldn't be none when you're probably already in a lot of pain by virtue of this disease. So I don't know why OO is able to take over in this regard when they go, like, it doesn't mean no pain or no long-term side effects. The last thing I want to flag out is that I know OO's way of engaging with this comparative was to go, you can't take experimental and other treatment and the conventional treatments at the same time because they will clash. I don't know what this means. I think the specific mechanism given by DLO was to say that treatments don't have a set date, but as the AIB, I assume chemo is done in phases. If you've done it for a while and it's not working per the scans, because I don't know, generally as an average person, I understand that people go for regular checkups. I assume this is the point at which you would stop. And OG to this regard, therefore, gives me better reasons as to why you can do conventional first, experimental second, which is why I don't think OO necessarily weighs up in this regard. Also, on the rich people, poor people point, I don't think this was significant enough to necessarily weigh up the debate for either side in terms of the first exchange. I think it was relatively deadlocked, but CG was able to come and clarify this, so points them on that. With that, yep, that summarizes the call. It is again CO, CG, OG, and then OO. If anyone has any questions about the OA or personal feedback, you're welcome to stay. If not, I think it might be lunch. Just head back to the main room. Thanks, everyone, and good luck
One
for the.
thing, I'm sorry to interrupt. I'm not sure if it's me audio issue, but I'm not sure if the last comparison between CG and CO was done.
CG and CO. Did I think I flagged it out when at the start I talked about CO and I flagged out why they were
Okay, cool.
CG. But would you like a short clarification?
I mean, not really, no. Just feedback. I'll text you later if that's all right.
Yeah, sure, no worries.
Thank you so much.
If it's possible, could we have feedback right now? Like, unless you're busy and you have lunch
No,
or something.
sure. Sorry, you're a CO, right?
Yeah. 1 second. Let me just check. Archit, you're here, no?
Yep.
Yeah. So I had a few questions, but first, just generally, if you had any feedback to CO, we'd like to hear that.
Okay, so I think your case was the most well mechanized in the round. I think evidently the responses are ahead of other teams where they are. What I think would be very helpful for you guys, and what might be more of a tiebreaker in rounds that are a lot closer is to flag out where you are responding. So I'm not sure what the meta is in the South Asian circuit, but like at least based on what I know of like ABP or whatever, judges often like it when whip like flags out how you are directly responding. So explaining directly why your extension is above your opening, or for whip to have either house by house or clash by clash comparison in terms of why it weighs you up. Otherwise, it's down to the judge, being a good judge, to track where the things you say implicitly respond. If they don't do that, then that's kind of a problem. So more clarity in terms of structure would be my main point of feedback. I think the content was great.
Okay. So I think one thing both Archit and I have been struggling with, and what we felt happened this round as well, is I think in attempts to sort of land the case entirely. I
Okay.
think we spent a lot of time trying to prove some things, and I think it ended up taking away time from what could have been spent on impacting or being like a bit more comparative in terms of explaining how this is relative to other teams. So just first on that, one, like, how would you suggest we tackle that as an issue, generally speaking? But secondly, for this round, do you think there was some material that was unnecessary or something that we could trim out and use for something more useful for this round?
Um, I think you guys cover everything quite broadly in this round, so I don't think there were new things that you necessarily could have added that would have been significantly better. I think at best I'd say the material and op whip about when we circumscribe the rights of individuals was something I think could be part of the extension in and of itself, but I don't think we were wrong in this round to go for a vertical extension. I'd say normally, right, like you should go for the vertical because it's very rarely that both opening half teams don't think of the most obvious or important thing in the round. So prioritizing vertical first over the quasi-horizontals that you do later, I think would have been the right strategic call regardless. And to that end, I don't think you overspent time in terms of proving these things. There were like 3 or 4 mechanisms, they were succinct, you moved on. Though what I think would have been better is to again shift some of that responsive material from whip up to first, because I think largely your case doesn't change in direction, and have whip spend more time impacting why you are important to the rest of the round in this regard. So why the things that you prove are significantly more important, or why you have a greater impact than your opening halves.
Sorry to be like a bit specific about this. Could you like illustrate what the responsive material you're talking about here? Like, what is material from this round that should have been at member instead?
Okay, so the first thing I would say should be up there is an explanation